أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. My dear fellow students, clients, and those who are appearing in any examination regarding the membership examination or fellowship examinations within the country or outside the country. And actually, I was dealing with previously about 2-3 weeks back, and that is called infection and the disease. That is called infectiology. Now, I have already told you that about 40 to 45% or more than that is included in internal medicine. And it is definitely a part of the OPD problem that you see these cases of urinary tract infection. And the important problem which is associated with this disease is that it is the recurrent disease, and it is usually not responded to the therapy in about, let's say, 30 to 40% of cases where there is a recurrence of infection, relapse occurs, and again the cycle goes on. Because the organisms which are responsible for this urinary tract infection, there are many organisms. Some are very common, some are uncommon, and some are rare. Now, this session is important in this context that practically you have to see these patients most often. Whether you are practicing general practicing, or you are going for the consultations, or going for the nephrology, is going for the gynecologist, etc. Even surgeons, they have the same problem. These people are visiting them because they are surgeons, and because they don't know about that. Specifically, the urology is the part of the surgery, and another because they are surgeons, and they refer to the nephrologist for the workout. The time is wasted actually, because one person goes to the general practitioner, he referred to the surgeon referred to the urologist referred to the nephrologist. So this problem is for everybody. Whether you are practicing at which level, it does not actually mean that you are not able to evaluate this infection. If you can understand properly, then you can handle these patients very nicely. I am Professor Sayyid Ali, and I am the Honorary Global Professor of Medicine without any name or fame or economics. This channel is free for all who are consented to watch these videos. Now let's see the introduction of it. That you know that first of all, repeat some part of the anatomy here. That the urinary tract. What is urinary tract? Urinary tract comprises starting from where the urine is formed. The whole of the nephron are kidneys, and they are collecting drugs. All are included. I mean, kidneys are included. Then the ureters, including the pelvis of the ureter, and ureters enter into the bladder in an oblique fashion, where the flap will form, which is called as a valve at the junction, and that is called a vesico-ureteral junction. And it is the part actually which is actually penetration of the way it penetrates into the bladder is important, because flap occurs of the mucosa when it enters, and it will form a sort of a sphincter there. Now, coming to the after the bladder, you go for the urethra. Urethra in the female is short, and in the male it is a big one. And the part of it which is very near, it is very near to the bladder, that is neck of the bladder, and then it comes afterwards what is called as a part which is related with the prostate gland, prostatic part, and then the penile part is concerned is a big one in males are concerned. So there are three parts, and from the neck of the bladder to the lower down, that is where the penile urethra starts. There are two valves. One is called sphincter vesicae and one is called sphincter urethrae. Sphincter vesicae is very, very close to the bladder. It is a part of the bladder. It is the actually it is under the influence of the autonomic system. If the bladder is full and there is a reflex generating from the bladder to the brain, it will cause urge to urination. You can definitely hold this urine by means of sphincter urethrae, which is just hardly 0.5 to 1 centimeter below. It is under your control, that is voluntary control. Remember this important, and remember another important point as this, that the accessory glands, they are secreting between sphincter vesicae and sphincter urethrae. It means that the seminal vesicles and prostatic duct and other small other accessory glands are there, secretions are coming out and collecting in there. But there are a lot of problems associated with this type of problem. Urge to urination and, we run amok to the urination, that is frequency of urination and the urgency of maturation and etc. etc. Many terminologies are used to describe this type of feeling. This is not my subject. I'm doing actually the urinary tract infection. In the cases of this inflammation, the upper part of the urinary tract and the lower part of the urinary tract. Upper part starts from the pelvis to the kidneys and lower down, that is lower urinary tract. And look the anatomy, you will see and you know about it. Then in females, the uterus is in front and the rectum is behind, and it is sandwiched between the two. And in the female, the urethra of the female, the membranous urethra, which is connecting outside. Outside it, there is a vagina, which is very close to it. Even the anal gland is very close to it, in both of the male and females. Now this anatomical relationship is important to understand. Why the infection recurs, why there is resistance, so much so that you cannot help the patient. The women are greater risk of developing the UTI than the men because of their anatomy, because of the structured opening very near to it. And among adults aged between 20 to 50 years, UTI are about 50-fold more common in women. Now, in the case of this very young age to the 50 years, fertile area, now the female are 50-fold more common urinary infections. Now, I've seen about, for example, I've seen in my life about 1,000 cases, more than that, around 1,000. 900 are the females of the urinary tract infection and about 150, 140 are males. Now remember, there is 550-fold more common in women. In our country, again, those people who are attending as urinary tract infection, they are mostly females. Hardly you will find any 2 or 3% or 4%, 5% males. And the males are affected after the age of 60 years or more because of the prostate, which is benign prostatic hyperplasia occurs, prostatic hyperplasia, BPH and prostatitis, etc. They are common in this age, after the age of 60 years. So it means that between 20 to 50 years, females are affected in higher frequency, but after 60 years of age, the males are affected because of the aging process and because of the anatomy, because of the poor immune response, etc. There are many factors are operating here. In women, this group mostly carries cystitis or pyelonephritis, inflammation of the nephron exactly, or they are the inflammation of the urinary bladder. The same age group, urethritis in the man or prostatitis, but due to increase in patient 50 years of, but the female male ratio decreases because of the increasing frequency of the prostatic enlargement and instrumentation in men. I already said here that is after the age of 60 years, more you find male patients, there are more than females in our country. Because I've seen after the 60 years of age, they are more prone to develop males this infection. Now this is the anatomy actually. This is the part, the pelvis, renal pelvis, and whole of the nephron, kidneys, the renal tubules, collecting tubules, etc. These are the upper part of the urinary tract, and lower part is starting from here to the hair, so the urethra, whole part. Now this part is involved actually. I've already said that. Now just look, this ureter is moving because of the contraction, and it's opening obliquely into the urinary bladder. This is the physiological sphincter which is present here, and it will definitely resist the vesico-ureteral reflux which is seen in diseases of the bladder, urinary bladder. You find the vesico-ureteral reflux is the problem, which is the ascending type of infection occurs. We have two types of infections. One is called the antegrade and second one is retrograde. Now ascending infection, antegrade, means that it is moving from here to the kidney. Rather the descending one is coming from upper to the lower down. Another important point is that females, the descending infection is definitely more important. While in cases of the males, the ascending infection is more important. Because the type of the organisms we see in this case, definitely they are important. Now coming to this anatomy again, you find the prostate gland, urethra, female cervix, they are very near to the bladder. This is sphincter, which I said is sphincter vesici, and down is sphincter urethrae. So it means the upper urinary tract infection and the lower urinary tract infection. Now coming to the pathophysiology, is this that the bacteria that most often cause the cystitis and the pyelonephritis are the following: inflammation of the kidney, inflammation of the bladder. Now coming to this, you see that in cases of the, mostly you find there are the gram-negative aerobic type of the bacteria you see. Like Escherichia coli, 75 to 95% of cases, and Klebsiella and Proteus mirabilis, Pseudomonas aeruginosa. And gram-positive bacteria, which is less common, as Streptococcus aureus and Enterococcus faecalis, which is one of the species of the Streptococcus group A, and Streptococcal agalacti, the group B Streptococci. And in hospitalized patients, you find that the Escherichia accounts about 50% of the cases. The gram-negative species, Klebsiella and the Proteus and the Enterobacterus and the Pseudomonas and the Serratia account for about 40% of the cases. And the gram-positive bacteria, like for example, Escherichia, Enterococcus faecalis or Staphylococcus saprophyticus, and Staphylococcus aureus occurs for the remaining infections, about 10 to 15% cases. And this is the nosocomial problem, that is hospitalized patients. It is definitely important subject for the as far as hospitalized patient are concerned, and in those who people are seem to be healthy in their males and the females of the age group, which I said about the 20 to 50 years, and after 50 years, I already said that the females reduction is there in the urinary tract infection is concerned. The males are more prone to develop this type of urinary tract infection. The pathogenesis is that the bacteria that cause urinary tract infections typically enter the bladder via the urethra. This is ascending infection. However, infection may also occur via the blood or lymph. It is a lower down to upper, retrograde. It is bleed. The lymph is also involved. It means that it is a parental type of infection. If it's there, it's coming from the blood or lymph. But it's not very common. But it is possible. As a part of the, what is called a septicemia, or in cases of the bacteremia, the kidneys may be involved. It is believed that the bacteria is usually transmitted to the urethra from the bowel. Urethra from the bowel, because bowel is very, very near. That sigmoid colon and the start of the, what is called as the colon and the descending colon, along with definitely what is rectal is concerned, is very near. This is very important to understand this problem, why it is recurrent, and why this type of organisms are seen, which are coliform bacteria. Because this said that it is theory, it is believed that they are crossing the bowel and then they attack the urinary tract in this fashion. That of female are more prone to develop this infection because of the anatomical relationship. After gaining entry to the bacteria, Escherichia coli are able to attach to the bladder wall and form a biofilm. Means there is a lot of coliform type of arrangement there to resist infection. And other organisms are helping this bacteria to grow. And that resists the immune response. It's not easy for the immune response to attack this type of a palisade type of formation to resist this infection. To resist it, the body's immune response failed often. Now, Escherichia coli is the single most common microorganism, followed by Klebsiella and Proteus species, to cause urinary tract infection. Remember, there are two types of organisms which you see the urine DR is concerned. I have already given a lecture to interpret the report of the urine RE. You will find in my channel this discussion. I said already there are two types. Nitrites are seen. Nitrites, you have to see the nitrites are present or not. Now nitrites, they are. This is an important part because the nitrogenous substance are releasing in the urine. So nitrates then goes to the nitrites, and nitrites convert into the ammonia. And ammonium, you know that it is alkaline in nature. So it's called the alkalinization, first of all. Secondly, there are three bacteria which are nitrite producing, and that is Escherichia coli, the Proteus species, and the third one is Klebsiella species. The Klebsiella pneumonia is the most common, Proteus mirabilis is most common. It is a nitrite producing organism. Always check that nitrites are present or not in the urine. A small amount or a large amount, it is not important, but it is present, and you doesn't find any WBC or very less WBC. It will be definitely you should label it according to American College of Nephrologists that this patient has been suffering from urinary tract infection. They said, does it mean that the pus cells are present or not? It is not important. Rather than the nitrites in the urine are important. So nitrate to nitrite to the ammonia, because of these organisms have got the enzymes which are important for the conversion of the nitrogenous substances. That is the end result is the nitrites. It will stay the nitrites for a few hours, that it will convert into ammonia. So it can be detected as nitrites in the urine. But after very many hours, you cannot detect it. A fresh sample is definitely important. The Klebsiella and Proteus species are frequently associated with the stone disease. These two are very prone to develop. If you find this Klebsiella and Proteus in the culture, it means that they are maybe associated with the stone disease. And calcium oxalate or mixed stones are frequently associated. And the presence of the gram-positive bacteria, such as other than that, the Enterococcus and the Streptococcus is increased, and other organisms are also there, maybe possibly of the Chlamydia trachomatis and other species of the Streptococci, other species of Streptococci. They are nitrite, and including with the Proteus, the Pseudomonas. They are not producing nitrites in the urine in most of the cases. Because Pseudomonas are, in the argument that they are producing nitrites or not. So in the conclusion that there are not much nitrites which you can detect with as far as Pseudomonas are concerned. The Pseudomonas are non-nitrate producing organisms. The increased resistance of the urinary pathogen to quinolone antibiotic, this is the problem, because you have to give mostly blind therapy with the quinolones. The resistance are developed in about 10 to 20 years. They've seen the second generation, and even now the third generation are in problem of the quinolones resistance. Now, first of all, is bladder infection. This is the key to the problem. Now, it is a sending infection. I said it is retrograde infection. The harmful pathogen enter the bladder, causing the inflammation, cystitis, and then it's crossing the ureter and ascend it to the kidney. In both male and females are concerned. The clinical features that the lower urinary tract infection is also referred to as a bladder infection. Most of cells due to bladder infection and UTI, lower urinary tract infection, the same. No, the most common symptoms are burning with urination and having to urinate frequency of micturition, in the absence of the vaginal discharge, and significant pain in the absence. These symptoms may vary from mild to severe, and in healthy women last an average of 6 days. Now, some pain above the pubic bone or discomfort of the lower back may be present. People experiencing an upper urinary tract infection or pyelonephritis may experience flank pain, fever, or nausea and vomiting, in addition to the classical symptoms you see in the lower urinary tract infection associated with the fever, flank pain, vomiting. It means that the organisms that are entering into the blood and causing the transient bacteremia and then frank bacteremia. Really, the urine may appear bloody or contain the visible pus in the urine. It is very, you see in the crystalline, glass or a container, you will see the pus in the urine, you see the blood in the urine, but not very common. Now, UTI have been associated with the onset of worsening of the delirium, dementia, and neuropsychiatric disorders such as depression and psychosis, mostly in the geriatric patients, old patients. However, there is insufficient evidence to determine whether UTI causes confusion, mental confusion. The reason for this are not known, but may involve a UTI-mediated SIRS, that is systemic inflammatory response syndrome, which affects the brain. Cytokines such as interleukin 6 produced as a part of the inflammatory response may produce the neuroinflammation, in turn affecting the dopaminergic and or glutamatergic neurotransmission as well as brain glucose metabolism. So this will cause this problem in the brain, and that is why the neuropsychiatric disorder, delirium, dementia occur. Especially, specifically speaking, in the old patients. This is the frank pus, cloudy urine, very, very clear evidence. or say that this is coming out, and you say that there is no urinary tract infection, it is rubbish, definitely. Now, some of the important age groups are children, because children cannot tell you the proper symptomatology. In young children, the only symptom of the urinary tract may be a fever, possibly the fever with the chills, because of the lack of the more obvious symptoms when females under the age of 2 or uncircumcised males less than a year exhibit a fever. A culture of the urine is recommended by many medical associations. You have to do the culture of the urine to rule out any urinary tract infection. In our country, if there is a fever with chills or rigors, the first diagnosis is malaria. Exclude malaria and other things which can cause the chills, for example, a localized collection of pus, or something like the sinusitis, tonsillitis, etc., etc. Other than that, viral infection can cause the chills as well. But for them, they are all excluded, and the only thing that is very important is urinary tract infection. Fever with chills or fever with rigors, intermittent type of a fever. Now, small babies may feed poorly, vomit out, they sleep more, but they show the signs of jaundice, with a hemolytic type of a jaundice. Specifically speaking, some of the organisms which are traveling into the blood as a bacteremia. In older children, new onset urinary incontinence. For example, the child is grown up 4 to 5 years, for example. In those cases, he has actually experienced the nocturnal enuresis. Now there is no nocturnal enuresis before. He started again to nocturnal enuresis, and he feels lazy. You cannot give the diet properly to the child. It means that there is something hidden inside his body, and it will reflect as this symptomatology in the children. Small children cannot tell you. They said about in 400 infants of 1 to 3 months of age with the UTI also have bacterial meningitis. It is associated with the bacterial meningitis is a part of the septicemia actually. The meningitis occurs in children of 1 to 3 months of age. If the patient has got bacterial meningitis, try to find the focus of infection, and you find as a urinary tract infection in these children, if you will investigate properly. In elderly, actually, again there will be a presentation, maybe vague symptomatology with incontinence of urine, a change in the mental status of fatigue as the only symptoms in these patients. They do not want to go outside. They are not able to take properly the foods. The concentration of them are poor, the memory is affected, and with you see the possibility of the fever, possibility of the even hypothermia, possibly the normal temperature, possibly 3 type of a problem occurs. Maybe possibly the fever is not documented, it is possible, but these type of symptomatology are indicative of something going wrong. Infection of the blood, that is sepsis or septicemia, the first symptoms. And elderly people have pre-existing incontinence or dementia. It will definitely affect on those people who have already got some problems of the avoiding the urine, or they have already diagnosed dementia. It will definitely enhance these problems. It is reasonable to obtain a urine culture in those with the signs of systemic infection and may be unable to report urinary symptoms such as when advanced dementia is present. You will find in the culture, you find in the blood. So blood culture should be done with the urine culture. Systemic signs of infection include like fever or increase in the temperature of more than 1.1. Hardly it is normally 98.4 is 99.8 or something like this, or around it is low grade fever. Usually occurs the chills or rigors and increased WBC in blood CBC. You will find neutrophil leukocytosis in most cases which are hidden. So this is the first session of urinary tract as concerned. It is important, my dear. You have to understand properly what are the problems which is going on, and those who are preparing FCP as part 2 definitely can be asked as if the patient is for the long case the paroxysm of unknown elevation or fever of unknown elevation or prolonged fever in a long case. They have to justify what are the probable causes. When the FCP part 1 is concerned, those who are appearing in the part 1, look the organisms, the microbiology, look the anatomy related with the pathology, and look the physiological aspects of it, how urine is formed and how it is collected and how it is voiding. So this is important as part 1 is concerned. Part 2 is definitely always important. Anything can be asked. So this is the end of session because it is a slightly important one. It will take time. I will divide it into session 1 and session 2. I will continue with the session 2 inshallah very in a 1 day or 2 day. Assalamu alaikum wa rahmatullahi wa barakatuhu. Wama alayna illal balagh.